All right, Dr. Ledford, attendance is looking pretty good.
Well, I think to be respectful of everyone's time, I think we'll go ahead and get started. I want to welcome everyone to this latest edition of the Grand Rounds, USF Grand Rounds. It's a unique pleasure for me today to present one of our children, or previous fellows. I call them our children, who's we share an allergy immunology section at the VA with the dedicated hospitalist group under the direction of Dr. Alex Rice. Dr. Hudey is an assistant professor here at the university and works with us part of the time and with Dr. Rice the rest of the time. And she embodies the mantra that our division chief, Dr. Richard Locke, states or preaches really to our fellows, is that you cannot be a competent allergist, immunologist, or specialist of any type without first being a good internist or pediatrician. And I know Stephanie's heard that from Dr. Locke many times, and she really does embody that because she is an excellent internist, it gives me a lot of pleasure to see her living this adage out, I guess it would say. But she's also an exceptional allergist immunologist. She's published quite extensively in infection-related problems with John Sleesman, which included HIV-related problems, and she's also published concerning non-type 2 asthma, which is one of the more difficult types of asthma to treat, and side effects of asthma therapy. So it's really a great personal pleasure for me to introduce Stephanie. And she's going to be talking about a very important topic, secondary immunodeficiency, or basically adults with immunodeficiency. And in an era where increasing diagnostic sophistication and the use of immunomodulator in immunosuppressive therapies are common, this is a very important topic for internists. So Stephanie, again, thank you for being with us this morning or this afternoon. And also thank you for being with our section. We really value your being a role model for our fellows. Thank you. Take it away.
Thank you, Dr. Ledford. I am very fortunate to be working here at the VA, working at USF, and the mentorship is amazing, led by Dr. Ledford, Locke, and Glom and Cho and everybody else that I have the opportunity to work with. So I have them to thank for everything. So we're going to be talking about secondary immunodeficiency, how to approach an adult with recurrent infections. It's kind of a broad topic, especially since I did want to touch at the end a bit on primary immunodeficiency in adults, because it can be hard to differentiate the two, and we'll talk about why that is. I don't have any disclosures. So for the learning objectives, we're going to learn to recognize different etiologies that you should consider when you're evaluating an adult patient with recurrent infections. So thinking about possible anatomic defects they might have, functional disorders, and then of course secondary causes of immunosuppression. We'll go into the details of those. And we're going to talk about the important components of doing a thorough clinical evaluation when you're assessing these patients. And then we'll talk also a bit about the laboratory tests that we use to properly assess different parts of the immune system, both for primary and secondary immune deficiency. So, like I said, we're gonna talk about different anatomic abnormalities, which is kind of the first thing to consider when you see an adult with recurrent infections, both congenital and acquired are possibilities. Talk about secondary immune disorder. So there's a lot of both medical conditions and treatments for conditions that can cause secondary immune problems. These are going to be far more common than the primary immune deficiencies in adults. So up to 30 times more common that we'll see those as opposed to primary. Although, as I'll touch on at the end, there is an increasing incidence of primary immune deficiency, and more so now than there used to be. And then, like I said, we'll talk about primary, which now there's different terminologies for this. One of them being IEI, or inborn errors of immunity. That's another way it's referred to. It's also, there's some that are referred to as PIRD, which is what I'll go into a little bit towards the end of the talk. So the big question first is, when do you get concerned about the number of infections an adult is having? So this is actually 10 warning signs of primary immune deficiency. This was made by the Jeffrey Modell Foundation. This is again focused around not missing a primary immune deficiency in an adult. So I find some of these, though, to be helpful when you're thinking about secondary immune deficiency as well, in terms of the infection part. So if you see an adult who has 2 or more new ear infections within a year, or they have 2 or more new sinus infections within a year, and that's in the absence of other reasons for sinus infections, which we'll talk about. If they have 1 pneumonia per year or more, and again, that's in the absence of other structural lung disease that would predispose them to pneumonia. If they have recurrent viral infections, we'll talk less about that because we're going to focus on hypogammaglobulinemia, but that's something to be thinking about. If they have a recurrent need for IV antibiotics, that raises concern. And if they have recurrent deep abscesses of the skin or abscesses in the internal organs, that's going to be a red flag as well. Some of these other ones are more, again, focused around not missing a primary immune deficiency. And we'll go into those a little bit towards the end. So how do you initially approach an adult with recurrent infections? So like I said, you first want to think about non-immunologic issues. So that's going to be anatomic or structural issues. So if you see these infections that are occurring at specific anatomical sites or locations, that makes you think that it's something else that's not necessarily the immune system. So first and foremost, you want to think about some of these things. If they have recurrent sinusitis, do they have nasal polyps? There are certain clinical signs of nasal polyps, like if they have anosmia or really refractory nasal congestion, if they have chronic drainage, that makes you think polyps. If they have an osteometal obstruction, if they have allergic rhinitis, we see a lot of patients with allergic rhinitis who get frequent sinus infections, and sometimes we do evaluate them for an immune problem, but a lot of times it's just the chronic inflammation that they have in their nose and in their sinuses from their allergy that is causing their recurrent sinusitis. It's not an actual underlying immune deficiency. Bronchopneumonia. So if they're getting recurrent pneumonias, you want to think about whether they're having microaspiration events, and we know the types of patients that this occurs in. If they may also have possible esophageal disease, really bad GERD, LPR, bronchial obstruction from a mass, a malignancy, for example. If they have smoking, if they're an active smoker or have smoking history with COPD, underlying lung disease, that's going to predispose them to pneumonia. Cystitis, so if the urinary stasis, if they have bladder outlet obstruction, a neurogenic bladder, if they have frequent urinary incontinence, if they have frequent instrumentation or chronic Foley. Again, these are things I think we're all pretty familiar with. Pyelonephritis, if they have renal stones or other obstruction like stricture or malignancy, reflux, and then cellulitis. We think about chronic lymphedema, venous insufficiency, if they had prior surgery and have lymphatic dysfunction in that extremity. They have scarring from previous episodes of cellulitis in the lymphatic system if they have poor hygiene. So again, things we see pretty frequently. So you definitely would think about these first before you think about what could be wrong with their immune system. So just a brief background to our immune system. Some of us probably haven't thought much about this since medical school. We have two major kind of arms, I guess, of the immune system. We have the innate immunity and the adaptive immunity. The innate are going to be our first responders. They have less specificity. That includes phagocytes, complement, and then there's dendritic cells involved, and mast cells, which are a little bit of a separate topic. And then adaptive immunity makes the primary cells made up are the B cells and T cells. B cells making antibodies, plasma cell secreting antibodies, and we have our effector T cells. It's difficult to look at these in isolation because they do have interaction. The innate and adaptive immunity do they interact with each other, but just think innate is our early first responders, less specificity. Adaptive is more sophisticated, more specificity, but it takes a little bit longer to develop. So the next thing you want to think about with recurrent infections is the pattern of infections, or what type of infections are they getting. So that helps you think about what the defect in the immune system may be. So in antibody deficiency, the main types of infections you see are recurrent sinopulmonary infections. You can also see recurrent GI diarrheal infections too. The most common bugs are encapsulated bacteria like Strep pneumoniae, H. flu, Moraxella, and then the kind of classic one for the GI bugs is Giardia, but you can see others like Campylobacter and Salmonella as well. For cell-mediated or T-cell defects, that's where you think more about viruses and fungal infections and opportunistic infections. So there's a huge list there. It can be viruses like CMV, EBV, HSV, non-tuberculous mycobacterium, Candida, Aspergillus, Cryptococcus, Histo. So a lot of things that we think of with opportunistic infections and viral and fungal infections. Phagocytic defects, you commonly see recurrent invasive skin and soft tissue infections, and you can see focal abscesses as well. We think about these more in the pediatric population. Catalase positive organisms is kind of the classic thing for that, and we're not going to really talk much about those today. And then complement deficiency, classically, you have the early and late complement defects, where it's a commonly tested question. With late complement defects, you would see nice serial infections. Also, not really going to talk about that much today. So we're going to focus on the antibody deficiency or the hypogammaglobulinemia, both primary and secondary. So how do you define hypogam? So anything below 700 is considered a low antibody level, or sort of low IgG level. And then there, you can further stratify the severity of the IgG deficiency into three categories. They're not really, in the literature, they're not labeled mild, moderate, or severe, but that's kind of how you can think of it. So anything around 200 or less is considered as severe hypogam, and then you have this kind of intermediate range, 200 to 400, and then 400 to 700. So you can kind of break down the severity of their IgG hypogam into those three brackets. So we're going to go through a case here. This is a 60-year-old female. She presents to an immunologist with recurrent episodes of sinusitis, 2 episodes of pneumonia, and one of those episodes did require hospitalization. So she has a past medical history of ITP that was treated with Rituximab, but that was 5 years ago. She denies any recurrent infections in childhood or until the last few years, she says. Her labs show low antibody levels. She has an IgG of 300 or 302. She has an IgM of 39 and an IgA of 26. So these are all low. Her pneumococcal titers, which we'll talk about in a bit, are inadequate, and her flow cytometry shows only 2% B cells. So that's also low. So this patient was started on immunoglobulin replacement therapy. This is kind of a modification of a real life case. So we're going to set that aside for a minute and talk a bit about Rituximab. So what is Rituximab? I'm sure we've all seen it used. It's quite common. It's an anti-CD20 chimeric monoclonal antibody. So it depletes CD20 B cells. It's kind of considered a pan B cell marker. It's expressed on all B cells except for plasma antibody secreting B cells. So it wipes out if you look at the stages here, it wipes out all pretty much except for the antibody secreting plasma cells. So its use is associated with secondary hypogam. As you can imagine, our B cells make our antibodies. If you're wiping out B cells, then you won't have antibodies with the exception of those made from the plasma cells. In some cases, the hypogam from rituximab can be persistent and it can lead to serious and recurrent infections. The association with hypogam is seen more when it's used for malignant conditions. So you can have rates ranging anywhere from 14 up to 50% of patients who are using rituximab for lymphoma develop a hypogam, and that's much higher compared to those that are using it for a rheumatologic indication like RA or vasculitis, where they'll have only 3 to 4%. So why is that? Oftentimes, when it's used for malignancy, it's used in combination with other immunosuppressants. So that is going to affect the risk for the post-rituximab secondary hypogam. So drugs like corticosteroids, mycophenolate, cyclophosphamide, those when used in combination with rituximab will increase the risk for developing secondary hypogam. The types of infections you would see with this are bacterial sinopulmonary infections, which makes sense based on what we had just talked about. Typically, when it's used in isolation, the B cell reconstitution would take about 6 to 9 months. However, when it's used in combination with other immune suppressing drugs or chemo, that can be up to 18 to 24 months. And then there are cases in the literature, not common, but there's quite a few, where the B cell depletion lasts for much longer, so even more than 10 years. And in this case, our patient received rituximab last 5 years ago. And we're going to revisit her case because there's a little bit more to it. But yeah, there can be prolonged hypogam in a minority of these patients. So because of that, the guidelines now recommend routine pre-rituximab screening to help identify patients that may have an underlying immune dysfunction that would put them at a higher risk for developing infectious complications and having prolonged hypogam, and we'll talk more about that. There are a lot of other B cell targeted therapies now that are used in adults. Secondary hypogam occurs with these as well, as you can imagine. The occurrence of secondary hypogam is seen more frequently because these drugs are being used more and more for a lot of indications. So for autoimmune, both rheumatologic and neurologic conditions, as well as a lot of hematologic oncologic conditions as well. So in addition to rituximab, there's some other second generation anti-CD20s that are that have been designed. They have, in general, lower immunogenicity than Ritux. So there's ocrelizumab. Some of them are a little difficult to say, but obinutuzumab, veltuzumab, and ofatumumab. So those are different anti-CD20 monoclonals, again, that are a little newer than rituximab. And then another B-cell targeted therapy is belimumab, which is actually an anti-BAFF or a monoclonal to B-cell activating factor. It's less associated, though, with causing hypogam. So these are some other immunosuppressive medications to consider when you're seeing a patient with secondary hypogam. So as we talked about, there's the anti-CD20. CD20 is a B cell marker, so it depletes B cells, causes hypogam. You have anti-CD38s. This is a plasma cell marker. So these are used for conditions like multiple myeloma. Those will decrease plasma cells specifically, but they've so they've been associated with hypogam. They've also been associated with a lymphopenia. And then we'll talk more about this in a minute. The CD19 CAR T cell therapies, these do cause significant B cell aplasia and hypogammaglobulinemia, in some cases can be prolonged. And then we have BTK inhibitors like ibrutinib. Bruton's tyrosine kinase is involved in B cell development. So basically, this affects the B cells maturation, you see decreased IgG levels. You can interestingly see increased IgA levels. And then there's bortezomib, which is a proteasome inhibition, which causes proteasome inhibition that leads to apoptosis of plasma cells that can cause hypogam, specifically with lupus nephritis for whatever reason. And then some other immunosuppressive medications, corticosteroids, we'll talk about on a separate slide. Methotrexate can cause a hypogam and can cause decreased antibody responses to some vaccines. Mycophenolate, again, like we mentioned before, when it's used in combination with rituximab, can cause a hypogam. Sulfasalazine is very rare to cause issues, and then cyclophosphamide as well can cause hypogam. So this is just a bit of a summary of some of those we talked about. So you can see rituximab, our anti-CD20s on the left, ocrelizumab, and you can see the bortezomib, and we'll talk about abatacept in a bit. That's a little bit different, but we'll come back to that one. And then you can see the anti-BAFF belimumab here. So as I mentioned, steroids. Steroids have been shown to cause a CD4 T-cell lymphopenia. That's the most commonly associated immune defect. There has been secondary hypogam described in up to, it's a range from 12 to 56% of patients on those, in those that are on chronic or high dose steroids. IgA and M are less affected than IgG. However, these patients don't appear to have an increased frequency or severity of infectious complications from the hypogam that they can develop. So the guidelines, or I guess the consensus statements, don't recommend doing IgG monitoring for these patients. Some other drugs that can also cause a secondary hypogam, anti-epileptics are a big one. I think these are often overlooked. I don't think a lot of people realize that they can cause a hypogam. So phenytoin can also cause a B and T, or as well as a B cell. It can cause a T cell lymphopenia as well. Carbamazepine, hypogam, B cell lymphopenia. Valproate, the same. And then lamotrigine specifically can cause an IgA deficiency. And then a couple other drugs, clozapine, chlorpromazine. These we're really not using as frequently nowadays. And then D-penicillamine and gold are some others kind of classically, but not really seen these days. So this is another case. This is a 64-year-old male. He has a history of head and neck cancer. He comes in he presented initially to hemo with concern for amyloidosis, but was diagnosed with IgA lambda multiple myeloma. His bone marrow showed 15 to 20% plasma cells. He was started on daratumumab, which is an anti-CD38 monoclonal antibody. So this is a plasma cell targeted monoclonal. This patient was admitted to the MICU with respiratory failure not too long after he started treatment. His exam showed a diffuse edema. CT showed multifocal pneumonia and edema in the lungs. Labs show a low albumin of 1.9, IgG of 241, IgA of 372, and IgM of 26. So IgG is the big kind of standout there, significantly decreased at 241. So this is a case of secondary hypogam from multiple myeloma. However, he is also on treatment for treatment with a drug that is associated with secondary hypogam as well. So you can see there's some overlap here between treatments and therapies for patients that can both contribute to the hypogam. So in multiple myeloma, the hypogam is from, you have clonal expansion of the paraprotein producing plasma cells. This leads to suppression of normal CD19 B cells and the plasma cell precursors. The immunoparesis can be seen up to 52% in smoldering multiple myeloma, even higher in newly diagnosed, up to 90%, and 75% in those who are in remission. And as there was one study that found infection was responsible for 45% of deaths within 6 months of diagnosis, with the respiratory tract infections being most frequent. The difficult thing with multiple myeloma is that, I'll talk a bit about this. So immunoglobulin replacement is used, but it hasn't been seen in the literature to be as beneficial for these patients as, for example, CLL that we'll talk about. But you can use immunoglobulin replacement for them. So CLL is probably the most common in the malignancies to cause a secondary hypogam. So this is due to the underlying nature of the condition, and also due to the treatments themselves that are used for CLL. They can cause secondary hypogam as well. So it's seen in up to 85% of patients. Infection-related deaths occur in up to 25 to even 50% of patients. So there's more specific guidelines for CLL than there is for multiple myeloma and lymphoma. So in those that have recurrent infections with hypogam, there are you can use immunoglobulin replacement, and I'll talk about a little bit more about cutoffs for when you would consider that. Sometimes prophylactic antibiotics will be used first as a trial prior to considering IG replacement, but it does have an FDA-approved indication for CLL as opposed to the others in which it's all off-label use. And then you have lymphoma, which has lower rates of hypogam than in the first two we discussed, but up to 7 to 15% before treatment. And then CD19 CAR T cell therapy. So this is kind of a newer treatment that is more novel, used. So CD19 CAR T specifically, it can be used for ALL and B cell lymphoma in adults. So because it depletes CD19 B cells, it's going to cause a secondary hypogam. Currently, there's these two CAR T cell therapies available. I'm not even going to try to pronounce those, but those two are used, and you can have a prolonged and significant hypogam and B cell aplasia, just obviously given the nature of how they work, and it can be associated with infections. Excuse me. So or a couple other possible secondary causes of hypogam to consider. So there's Good syndrome, not common. This is a thymoma that's associated with hypogam. And then transplant patients, so hematopoietic stem cell transplant as well as solid organ transplant. Again, a lot of the drugs used for transplant are going to put these patients at risk for B cell depletion and hypogam. So a few other things to think about. Protein losing conditions, so both nephropathies, so we have nephrotic syndromes that cause, or protein losing nephropathy that cause loss of the immunoglobulin. So you have a lot of primary glomerular causes of this, and then a lot of secondary causes as well. So some secondary causes to think about: diabetic nephropathy, lupus, amyloidosis, myeloma, lymphoma, medications can cause it, infections, and some congenital syndromes as well. So not only do you have loss of protein in the urine, but it's also seen that you can have impaired synthesis of the IgG itself. And then obviously treatments for these too. So we use B cell targeted therapies for treating these. So that's going to just further contribute to the hypogam. And then protein losing enteropathies. So basically there's three things that can happen. So you have intestinal leakage of plasma proteins that can be due to, number one, you can have mucosal injury from an IBD, like an erosive or ulcerative GI disorder, Crohn's, ulcerative colitis. You can have increased mucosal permeability, and you can have intestinal loss of lymphatic fluid from lymphatic obstruction. I'll talk more about this on the next slide, but this is something called lymphangiectasia. So if you should suspect this in a patient who appears edematous, has low albumin, has diarrhea, and you've excluded other causes of protein loss. You can obtain an alpha-1 antitrypsin in the stool. They'll have increased clearance of this, and that would be consistent with the diagnosis of a protein-losing enteropathy. Some other labs you can obtain include albumin, fibrinogen, cholesterol transferrin, ceruloplasmin, and then fat-soluble vitamin. All of these would be decreased potentially in these patients. As I mentioned, there's something called lymphangiectasia. There's both primary and secondary. So what happens is you have dilated small intestinal lymphatic channels, and then there's impaired lymph drainage and lymphatic obstruction that occurs. And then you have leakage of the lymph into the intestinal lumen, and then you have loss of proteins. And with that comes loss of the immunoglobulin and loss of lymphocytes as well. So the primary causes, you can have loss of function mutations in these markers, CD55 and GAT1. And then there's a lot of secondary causes, like, for example, certain types of structural heart disease, like having ASD, certain infectious neoplastic chemotherapy regimens, and having cirrhosis as well can be associated as a secondary cause. And then some other causes of protein loss that can lead to hypogam include peritoneal dialysis, sort of severe burns, and even patients with severe dermatitis of the skin too. So a couple other things to consider is rheumatologic and neurologic conditions. So you can see secondary hypogam with these, and it's really not the disease itself, but the immunosuppressive therapies that are used to treat the diseases. ANCA-associated vasculitis, you can see hypogam with that, with EGPA, JIA, RA, and SLE, and then with MS as well as NMO, all diseases to consider when a patient has that and they have a hypogam. I'll talk a bit more about autoimmune conditions later. The thing that kind of, I guess, makes this a little more confusing is that not a lot of times, but sometimes IVIG is used for immunomodulatory therapy in some of these conditions. So you're giving them IgG, and so you may not see the hypogam initially if you're supplementing them with IgG. So it's a bit more confusing, but something to keep in mind. So this is a good summary slide of a lot of the things we've talked about. So both those that cause deficient production of antibody or immunoglobulin, and those that cause loss of the antibody or immunoglobulin. So we talked about CLL, lymphoma, we talked about myeloma, we talked about leukemias, all on the left side. We talked about those that are drug-related, so the B-cell targeted therapies, we talked about some of those, not all of them. And then we talked about the anti-epileptic drugs. We didn't touch as much on the tyrosine kinase inhibitors, but those are there as well. And then I think we covered most of the others. Transplant, we talked about both solid organ and hematopoietic stem cell, and then protein loss, renal and GI. We didn't talk about all of the GI loss syndromes. A lot of those are quite rare, but just to be aware of them, they're listed there. And then we talked about burns, severe dermatitis. And then lastly, there's you can have increased IgG catabolism in myotonic dystrophy. Again, not going to be something that we see very, very often, but just that's kind of another possible cause of hypogam. Malnutrition we really didn't talk about, but that's pretty self-explanatory, and then HIV as well. And we didn't talk about chylothorax as well as a possible cause. So how do you evaluate these patients? How do you manage these patients? So first of all, if you see a patient with recurrent, severe, or unusual infections, you want to check an IgG level. Especially if you think they're receiving a treatment that would, one of those things we talked about that could cause secondary hypogam. If it's low and it was checked a little bit ago, a couple months ago, for example, you want to recheck it to see if that was a transient hypogam or if it's still persistent. You also want to consider checking IgA and M as well to see if it's just an isolated low IgG or if they have low A and M as well. And then the next step, what we would normally do is look at specific antibody titers for both protein and polysaccharide antigen. So tetanus diphtheria being protein and pneumococcal or strep pneumonia being protein antigens to see not only do they have antibodies, but are their antibodies functional? Are they able to make specific antibody or make a specific response to antigen? And then you can consider if they have inadequate responses. Again, this is going to completely depend on the clinical scenario. So whether you're going to vaccinate them or not is, what their underlying condition is. But in the appropriate setting, you can consider vaccinating them to then reobtain titers to assess their response to the vaccination. That's something we do both in primary and secondary in immunodeficiency to determine if somebody's able to make an adequate response to a vaccine. And then further from that, you can look at lymphocyte subsets, perform T and B cell phenotyping. These are all things that can be pretty easily ordered. I do them at the VA, not infrequently. So this is per the consensus statement. I think I have it here. It's a little bit further, but this is one approach that's recommended in the kind of the guidelines for how to approach secondary hypogam. So if you have a patient with a recurrent severe unusual infections and they have an IgG of less than 700, remember that was our cutoff for a low IgG, and it's associated with other hypogam as well, either A or M, and they have suboptimal response to vaccination, then you want to consider trialing IgG replacement therapy. Again, it's going to depend a bit on their underlying medical condition. Same if they have an isolated low IgG less than 400, particularly in solid organ and heme malignancy, that in the guidelines is recommended as a consideration for replacement therapy. So those are patients that have infections. For those that don't have infections, but they have a very low IgG, so if it's less than 150, that's severely low IgG, that puts them at significant risk for developing a severe, even life-threatening infection. So you should highly consider trialing replacement therapy even before they've actually developed any infections. And then if it's in this range of 150 to 400, you can consider it. It's kind of a shared decision-making option at that point. That's a little bit difficult territory. So typically for replacement therapy, we start at a dose of 400 to 600 mg per kg, and that's dosed monthly. So IVIG is typically given monthly. Sub-QIG, we're using more and more frequently. That is subcutaneously administered. It can be weekly and it can be every other week. It depends on the formulation. So you would just adjust the dosing based on how many times per month they're getting it. Initially, you want to wait 3 months before, this is for monitoring their response. You want to wait 3 months before you check an IgG. If they're on IV, you would do a trough level. So you would check it right before they're due for their next dose so that you were getting their lowest IgG level when you're measuring it right before they're due. And you would adjust their dose as needed. So the recommended starting level goal would be 800, and then you would adjust based on the patient's clinical response if they're still having infections or not. And then periodically assessing them every 6 to 12 months thereafter is recommended. So I want to jump for the end of the talk. I want to talk about primary immune deficiency in adults. So like we said, the vast majority of patients we see are going to have a secondary immune deficiency, but primary immune deficiencies are on the rise. So the vast majority of them, remember I said they're referred to either PID or inborn errors of immunity or IEI. The vast majority of them are antibody deficiencies or humoral immune deficiencies, 65%, followed by combined or T and B cell immune deficiency. So what kind of adds to the complexity of all of this is the fact that we're realizing more and more that these conditions have a lot of them have a significant component of immune dysregulation and can actually present with autoimmunity or lymphoproliferation before they present with infections. So it's not your classic patient with recurrent infections who comes in. It can be a patient with autoimmunity and perhaps a malignancy before you see the frequency of infections that kind of used to be expected. So just to summarize, there's a lot of non-infectious manifestations of primary immune deficiency. The most common would be autoimmune cytopenias, ITP, autoimmune hemolytic anemia. And then endocrinopathies can be quite common too, like an autoimmune thyroiditis, type 1 diabetes, thyroid disease in general, Addison's. Splenomegaly or hepatosplenomegaly is seen in some of these patients because of the immune dysregulation. Lymphomas are more common, B-cell lymphomas, GI lymphomas, and then interstitial lung disease. We see there's a specific type called GL-ILD that we see with our CVID patients. So they may have significant lung disease. Atrophic gastritis, chronic enteropathies, so patients with chronic diarrhea, and then they have further losses that way, like we talked about earlier, the antibody losses through the gut, and then autoimmune liver disease as well. So as you can see, this makes things a bit complicated because some of these conditions we use therapies for that can cause hypogam. So it becomes a bit confusing when you then see hypogam to determine if they had it to begin with or if they developed it as a result of a therapy that they received for one of these conditions of which are associated with primary immune deficiency. So it becomes very complicated. So this is just a little bit further display of the non-infectious manifestations of primary immune deficiency. So you can see on the left those that more commonly are associated with infection. So SCID, that's going to be something you see in peds, like newborn SCID. There's different types, but primarily are going to be infectious presentation. XLA is X-linked agammaglobulinemia. They don't have any B cells, no antibodies. And then you have DeGeorge syndrome, chronic granulomatous disease, Wiskott-Aldrich, hyper-IgM. So as you go from left to right, there's more association with these other like autoimmune and immune dysregulation issues. But when you look towards the right side, those are the ones you really predominantly see more is the non-infectious presentations and complications. So APOSED is primarily endocrine issues. And then ALPS, again, a lot of endocrinopathies in those patients. Same thing with IPEX. And then we have our kind of middle ground here, CVID and our combined immune deficiencies, where they do have infections, they do have sinopulmonary infections, but they also will have autoimmunity, like the autoimmune cytopenias and the endocrinopathies. And you can see here, there's a lot of, we're identifying more and more monogenic causes for these immune deficiencies. So we used to kind of group CVID into this bucket. And now we're able to, with genetic testing that we're doing more frequently, we're able to figure out what their specific monogenic defect is. And there's some that are specifically known to be associated with these other non-infectious manifestations, like, for example, CTLA, CTLA4 haploinsufficiency, and LRBA deficiency. So I'll come back to that. So the first case we talked about earlier, our patient that received Rituximab. So as you can see, she actually had a history of ITP. That's why she received Rituximab to begin with. So, and what was interesting in her case is that she got Rituximab 5 years ago. So in most cases, you wouldn't expect her to still have prolonged hypogam 5 years after. But like I did say, there are some patients that can have prolonged hypogam. But the question here is, did she have an issue with her immune system that preceded her receiving Rituximab? And it wasn't identified because she never had antibody levels checked. And so that's kind of what we're dealing with a lot nowadays, is we're seeing patients who receive treatments for these conditions, these malignancies, these autoimmunities, that then are causing the immune abnormalities, and then they're coming to us, and we're determining what came first. Did they have the immune deficiency all along that presented with the non-infectious symptoms, or is it all the result of the treatment they received? So it's a bit complicated. So in this case, what we're doing more and more frequently is we're using genetic testing, and that also isn't perfect because it's complicated. But there's so just getting back to this patient. So she is a modification of a real life case. So this patient did undergo in vitro genetic testing, a PID panel, and was found to have LRBA deficiency, which, as we talked about on our previous slide, is one of the monogenic causes of CVID, or now it's really considered a CVID-like illness. So what is CVID? This is probably one of the more common primary immune deficiencies that we will see in adults. So it stands for common variable immune deficiency. So these patients have to have a markedly low IgG, at least 2 standard deviations below the mean. They also have to have either a low IgA or a low IgM. They don't have to have both. And then they will have poor response to vaccines. Those titers we talked about that we check to tetanus, diphtheria, and pneumococcal, they'll have a poor response to either one or some of those. And then obviously, if you're labeling them with this, you want to make sure you've excluded all those other causes that we talked about. Excuse me. So again, like I kind of touched on already, it's difficult in some cases to figure out what came first. Was it the immune deficiency, or was it acquired from treatment they received for the manifestations of this underlying hidden immune deficiency? So the point of this case really is to stress the importance of screening patients for primary immune deficiency before they're put on these immunosuppressive treatments, when conditions known to cause secondary hypogam are diagnosed. So so now it's kind of thought the patients who eventually develop recurrent infections with Ritux likely had a baseline subclinical immune dysfunction that it then became unmasked or augmented by the Rituximab. So that's what's kind of thought now as the leading theory for these patients that we see who received Rituximab years ago and still have poor antibody levels. Some of them with genetic testing, we can identify a cause, and some we still can't. Our genetic testing has a long way to go still. So CVID, this figure probably now is outdated because this is changing so rapidly, but as of the time this was made, CVID there were only monogenic causes for an estimated 2 to 10% of patients, most common being LRBA and PI3 kinase, and then CTLA4 haploinsufficiency. So the rest have an unknown genetic cause. But again, I think that number is probably higher now, the more genetic testing that we're doing. So this is the panel that we use. It's an in vitae primary immune deficiency panel. When I was a fellow, I believe there were around 400, maybe slightly less than 400 genes in this panel, and now there's up to 474. So it's constantly increasing. This company actually was just bought by LabCorp. I think it was announced this week. So it's a LabCorp company now, or will be. So this helps us in these patients who've received immunosuppressive therapy, and then we can't perform the baseline evaluation that we normally would because the clinical picture is a little more confusing now. So I just want to talk about just briefly, some of the other tests that we use to assess the immune system. So these are things that really are specific to the immunologist and are a bit out of the scope of what would be, expected or I guess required for internal medicine. Besides, obviously, CBC with diff, looking at absolute lymphocyte and neutrophil counts. And then I think it's reasonable to look at specific antibody titers. They're not that difficult to order, but oftentimes we are still the ones that are doing those. And I think it's very reasonable for also an internist to look at immunoglobulin levels. The rest of this are things that we're doing usually, like flow cytometry. I mean, obviously hemonc is for other reasons too. But after our initial assessment, we'll look at flow cytometry, and then some of these other tests are really more specific to pediatric conditions that would typically be diagnosed in peds. So I'm not going to go into the details, but just you can kind of see the different types of studies we look at, both for quantitative and qualitative assessment of the immune system, depending on again, the types of infections they're having and where we think the issue with their immune system may be. As I mentioned before, we use vaccine titers to assess whether their antibodies actually work. So not only what are the antibody counts or numbers, but or is a person able to make specific antibodies? So we have protein antigens, diphtheria, and tetanus. So these require helper T cells to isotype switch and make the antibodies. And so this is partially assessing T cell function as well. And then we have polysaccharide antigens, which would be our pneumococcal titers. So if we're trying to just simply look at their B cells, how their B cells work, we pay more attention to their pneumococcal titers because those are T cell independent responses. So that gives us an idea specifically without T cell help how their B cells are working. So this is kind of a little bit of what I already showed before, but this is kind of the approach, the stepwise approach that we would take for testing in workup of a suspected immune deficiency. We already talked about CBC, looking at immunoglobulin counts, and then looking at antibody titers. And then we look at specific lymphocyte subsets, depending on, usually we will look at T, B, NK cells to start with, and then we can look at further like memory T cell subsets and some other markers too. So those are kind of our first two steps in assessment. And then we get into more specific tests, like looking at lymphocyte proliferation to mitogen antigens. And then the rest, we talked about this, the gene panel is usually kind of something we would do next. Excuse me. And then again, the rest of these are going to be more specific to what your underlying concern is with their immune system, and some of those much more commonly performed in the pediatric population. So just to summarize, I think what I tried to kind of explain or talk about was how it's important to think about all the different possible etiologies for adult patients with recurrent infections, whether it's an anatomical issue, whether it's a secondary cause from immunosuppression, all those other secondary causes we talked about, or whether this is actually an underlying primary immune deficiency or inborn error of immunity that is now coming to light after these patients have been seen for their autoimmunity and their malignancy or their lymphoproliferative disease. And then we're just now kind of realizing that they have these recurrent infections as well. And then lastly, like I mentioned, we're realizing the importance of screening patients who are going to receive these treatments, whether it's for a rheumatologic condition or for a malignancy, for doing basic immunoglobulins, and possibly looking at response to vaccines before we initiate their treatments. So we have kind of a more clear picture before they receive a lot of these immunosuppressive treatments. So that's it.
Well, thank you. I think we have a few minutes for questions if we have any. I don't see any in the chat, but does anybody want to raise their hand and ask a question? I do think it bears emphasis that the common variable immunodeficiency patient who has immune dysregulation is life expectancy is shortened even with gamma globulin replacement because of the immune complications. In other words, the gamma globulin can reduce the sinopulmonary infection, but it doesn't correct the underlying immune dysfunction that about a third of the CVID patients have that leads to a variety of problems that, frankly, the antibody treatment doesn't help that much.
Yeah.
There was a question about infection and obesity. Is there any correlation of infection and obesity?
Not that I read in any of the literature. Yeah, the only thing would be, with the issues with hygiene and cellulitis, we see more issues with cellulitis in obese patients. Some of that because of hygiene and the edema associated, but that otherwise with the immune system, not that I read or that I've seen.
And Dr. Hennings asked, is there any specific complications of gamma globulin infusions?
Complications?
Of giving gamma globulin infusions?
So in general, very well tolerated. We have some patients who we do pre-medicate, but some patients can develop headaches. That's kind of like the main issue. We definitely prefer using sub-Q nowadays because you can get a more steady state of their IgG throughout the month. You don't have these fluctuations in their IgG level that occurs when they're getting monthly IVIG. Some patients really most patients really do great with sub-Q, but some of them really don't like to do it themselves at home. But typically it's administered in their abdomen or in their thighs, and they can do it themselves after being taught. But there's been like some cases associated with it, like an aseptic meningitis. I'm trying to think of nothing huge. I don't know, Dr. Ledford, if you have any other.
There were reports, and it's still in the label, of cerebrovascular accidents, prothrombotic events associated, particularly in high-dose gamma globulin therapies that were given for autoimmune conditions. Most of that, though, was corrected by purification processes that removed the procoagulant factors. So the concern for that has dramatically dropped. However, the label still contains that language that there's an increased risk of stroke and other cardiovascular events, DVT, and so forth. So patients, of course, could see that or be aware. They need to be made aware of that. But again, I think it historically it's no longer an issue as much or even at all, from my opinion. But sub-Q reduces that a lot because again, they don't get the huge amounts all at once, which is another reason they were getting those events. Well, I don't see any more questions, Stephanie. You did a phenomenal job, and we knew that would happen, and we're so proud of you and happy to have you with us, and encourage the residents to do rotations through allergy immunology so they can work with Stephanie. If they don't do that, then they can have her as their attending as a hospice, so you can get Stephanie both ways. And she can also tell you about travel. She knows more about travel than I think almost anybody. So ask her about her next destination. It'll be somewhere exotic. It won't be Orlando, I can tell you that.
We've got
No
Joseph
knock on
Dasso that
Orlando,
has his
but
hand up.
They didn't have any bottles of diet root beer.
Okay.
I didn't
Okay.
get
All right.
real
Well,
root beer.
thanks
I gotta
again,
go-
everyone.
Okay, I go to
Yeah.
Target if you want me to get.
Don't forget about
Dr.
your
Dasso, do you want to
Yes,
ask your question?
yes, I know it can be
Tomorrow, so
overwhelming with so many things to check with an immunodeficiency, but I want to know your opinion. What about just checking vitamin D, since a good percentage of the population is vitamin D deficient, and we know that vitamin D plays a very important role for immunity, such as against viral infections and that.
Yeah.
And one other thing too is also, I think, diet is very important too. If one eats a Western diet that can be pro-inflammatory, can exacerbate the immune status of the patient.
Yeah. Yeah, I know. Yeah, anecdotally, there's not really much I actually didn't see much in the literature regarding vitamin D either. I mean, that's something that's easy enough for us to check, but it's not mentioned as one of the recommended
Right.
things to look at, but certainly a consideration. Same thing with diet. I mean, I know definitely our inflammatory diets don't help with any of this, but I don't
Right.
think there's been to my knowledge, a lot of specific research on that. So it's not really mentioned from the literature I was looking at, but
Right.
a good point.
Thank you.
All right, thank you. Thank you, everybody, and thank you, Dr. Ledford.
Yeah. Don't forget about your CME credit. It's on the chat if you need to do that CME thing. Don't forget. All right. Thanks. Everyone have a good afternoon.
Bye.